Surprise.
Good afternoon and welcome to the 49th of the COVID calls. This is a daily discussion of the COVID-19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at Drexel University in Philadelphia. Today we have a discussion about COVID-19 in Singapore and Indonesia with Sulfikar Amir. You can catch COVID calls live every weekday at 5 p.m. Eastern Time on YouTube. Just go to the COVID calls YouTube channel to watch live. You can hear the COVID calls recorded as podcasts on soundcloud.com. You can also keep up with COVID calls via Twitter using the handle @US of Disaster or @COVIDCalls. Please do help spread the word and send suggestions for future guests and topics. Please feel free to suggest yourself as well. On Friday, I will talk about lungs, breathing, and COVID-19 with James Dodd and Javi Carroll of the University of Bristol and their Life of Breath program there, and also Sarah Milov from the University of Virginia. She's the author of The Cigarette, A Political History. As of today, May 21st, 2020, there are 5,047,377 confirmed cases of COVID-19 globally, according to the Johns Hopkins University Coronavirus Resource Center. That's up from 4,952,139 cases yesterday. 1,562,714 of those cases are in the United States, up from 1,539,633 yesterday. There are now a total of 93,863 deaths reported in the United States. That's up from 92,712 yesterday. As a way to bring humanity to the numbers, I've been reading a life story every day, and I'd like to continue that now. This is the obituary of Devin Taquino by John McGonigal. This was published in the Pittsburgh Post-Gazette, April 15th. Rebecca Taquino is a self-described background person who is happier when nobody knows who she is. This situation, talking to reporters, divulging sensitive information, reliving the worst few weeks of her life, is understandably not comfortable for her. But Ms. Taquino believes that in keeping with his lasting memory, it's necessary to tell her husband's story. He would want to help, Ms. Taquino said, so that's what we're doing. Devin Taquino of Denora, Pennsylvania, died April the 10th of COVID-19 at West Penn Hospital. He was 47 years old and a father of 3 with, to the family's knowledge, no underlying health concerns that would lead anyone to believe he was at high risk for the novel coronavirus. We have no idea why it hit him so hard. We don't know how he got it. We don't know who brought it to him, Ms. Taquino said. It could happen to anybody. Just assuming that the senior community is the only section of the population that's going to be adversely affected by COVID-19 is wrong. People need to really get that in their heads and realize that this is real. COVID-19 became real and personal for the Taquinos a few weeks ago. On March 20th, Mr. Taquino started running a low-grade fever, coupled with what they thought were intestinal issues stemming from a stomach virus. He dealt with that over the weekend and was fine by that Monday. I'm so sad because I was looking forward to calling off work, Mr. Taquino told his wife. He went to work at the TTEC call center in Uniontown on that Monday, and experienced a slight cough, but nothing too serious. Tuesday, though, brought more stomach issues. Mr. Taquino left work after 60 minutes or so, came home and slept for 16 hours. For someone who often played video games, Resident Evil was his go-to, and made music at home late into the night, anything more than 6 hours of sleep was out of the ordinary. Ms. Taquino said she forced him out of bed on the morning of March 25th and took him with her sister to the closest Med Express urgent care. The physicians there noted that his oxygen levels were so low that he needed to go to the hospital immediately. The urgent care facility wanted to call an ambulance, But the family instead drove Mr. Taquino to Monongahela Valley Hospital in Washington County. Ms. Taquino dropped off her husband at the emergency entrance and never saw him in person again. Due to safety precautions, she and her family were not allowed in the hospital. Mr. Taquino was initially diagnosed with pneumonia, though he tested positive for the novel coronavirus the following day. He was moved from an isolation room to the intensive care unit, and just days later, on March 29th, Mr. Taquino was heavily sedated and put on a ventilator. He wasn't in a medically induced coma, but Ms. Taquino said he was never conscious from that day forward. At no point while hospitalized did Mr. Taquino's condition improve. He was transferred to West Penn Hospital in Bloomfield on March 31st. His lungs were compromised, his kidneys failed, and he needed 6 different medications to keep his blood pressure up. Ms. Taquino was informed that if his heart stopped at any point, it would be impossible to bring him back via CPR or with. Last Thursday, the doctor in charge at West Penn had their phone held up in Mr. Taquino's room so that his family could FaceTime with him. He wasn't conscious, but Ms. Taquino and their 3 children, Jonathan, Madeline, and Christopher, said goodbye that night. The next morning, around 8:15 a.m., the doctor called Ms. Taquino to let her know that her husband started losing his pulse. 30 minutes later, he died. Ms. Taquino and her family weren't able to be with him when he died. Ms. Taquino and her older son, Jonathan, tested positive for COVID-19, but feel fine now. None of their family members, not even Ms. Taquino's sister, who tested negative, could hover outside his room or be in the hospital. Instead, West Penn Hospital nurses stood by his bed so he didn't die alone, a gesture Mrs. Taquino greatly appreciated. The staffs at both hospitals were absolutely incredible, Ms. Taquino said. The doctors and the nurses, they were so attentive to us to make sure we were doing okay, just really supportive of us. And they tried, oh my God, they tried so hard to help him, and he just would not cooperate. It didn't matter what they did, nothing made a dent. Mr. Taquino, an avid Genesis and Rush fan who enjoyed all kinds of music, as long as it wasn't country, also loved trains. He studied old maps and the railroad history of Denora, pointing out where tracks used to be whenever the family drove around town. Ms. Taquino said her husband was a proud nerd, someone passionate about his hobbies and the people with whom he shared them. If he loved something, he loved it, Ms. Taquino said. He didn't go halfway on anything. It was all or nothing with Devin. He loved everybody. I don't know if he's ever met somebody he didn't like, and nobody's ever met him and didn't like him. Okay, I'm going to turn to the discussion. I'm so excited to speak with my guest today, who's an old friend. Sulfikar Amir is an associate professor of science, technology, and society, and a faculty member in sociology at Nanyang Technological University in Singapore. He is the editor of the Sociotechnical Constitution of Resilience, a new perspective on governing risk and disaster, and he's the author of The Technological State in Indonesia, the Co-Constitution of High Technology and Authoritarian Politics. And he's also the author of many essays and articles as well. His ongoing project now examines hidden vulnerability leading to nuclear meltdown in the Fukushima nuclear disaster. He has developed a framework of socio-technical resilience to assess the capacity of socio-technical systems for responding to disruption and crisis. He is also a documentary filmmaker. He has directed and produced 3 documentary films, all focusing on nuclear issues. The latest one is Healing Fukushima, which I understand you can watch on YouTube, and I strongly recommend that you do. It's an extraordinary film. It chronicles the role and experiences of medical experts in Fukushima in dealing with radiation hazard in the aftermath of nuclear disasters. Sulfikar Amir, welcome to COVIDCalls.
Thanks for having me, Scott. Good to see you.
Good to see you too. And I want to remind people that you can get questions in using YouTube Live. You just put your question in the chat there and we'll get that question, or you can email me directly, sgk23@drexel.edu, or you can put your question on Twitter and just make sure to tag me at US of Disaster. So Sulfikar, I want to start the way I've been starting with everyone in this, just to find out how you're doing, where you're calling from, and how things are there.
Okay, thank you for asking. So I'm doing quite well, me and my family. we've been staying at home for maybe 7 weeks now. So I'm calling from Singapore, more specifically from NTU campus where I live with my family. And yeah, I think we're doing quite well. Singapore has been under lockdown for since I think April 7th. And the government decided to, well, the first phase was 4 weeks, and then 2 weeks into the lockdown, the government decided to extend it another 4 weeks. So it's gonna be, it's gonna end on June 1st. So June 2nd, there will be some reopening in some, sectors in society, in the city.
I checked the numbers today. First of all, I should have said thank you for coming on at what's 5:12 in the morning right now there for you on Friday. It's much appreciated. I checked the numbers and I saw there had been 23 deaths in Singapore from COVID-19. So you've kept it seems that the government has kept the death rate down, but can you walk us through a little bit of the sort of trajectory here? How did COVID-19 first manifest itself in Singapore? What was the initial reaction of the government, of institutions there?
Okay, so the first confirmed case of COVID-19 in Singapore was announced, I think, sometime in January, in the third week of January, and the patient zero is a Chinese national from Wuhan, and after that it increased to 13 cases, and the first case involving Singaporean local Singaporean was on January 31st. And 1 week after that, it jumped to around 33 people, and that's when the government decided to change the emergency the warning system to orange status. So Singapore has this system of labeling the emergency situation called DORSCON, and the highest one is red, and in February, the government changed it from, I think, green or yellow to orange. Yeah, from yellow to orange. And for a while, the situation was seemed to be under control until in early March, there's a new cluster forming among migrant workers in Singapore, and this is when the crisis began to to spread out more rapidly. And yeah, and then when the COVID-19 reached this particular population, it started to increase the sort of the anxiety among Singaporeans, and that's when the government decided, okay, I think we need to take a more strict measures. And early April, they decided to go on lockdown.
So tell us a little bit about the health system in Singapore. You have a national health system. Do you have a national Centers for Disease Control? What's the structure like in terms of, because you were describing this sort of yellow to orange to red. So somebody's making these judgments and putting out these announcements. How is it structured there?
Okay, so before I give you the details of the healthcare system, we need to go back to 2003 when SARS outbreak reached Singapore. So Singapore was one of the few countries back in 2003 that was affected by SARS. And similar to COVID-19, SARS originated in China and then spread to other countries, including the US, Canada, Hong Kong, of course, is the ground zero of the outbreak, Japan, South Korea, Taiwan, and etc. So Singapore was one of the countries affected by SARS. And it was quite traumatic experience because at the time, the outbreak killed 33 local Singaporeans. And it infected around 300 people, and Singapore has to be locked down for 2 months. And it cost Singapore around $50 billion dollars because of the lockdown of the country and the isolations of Singapore from from travelers, foreign travelers. So this experience really gives something to the governments that they feel vulnerable to a similar this kind of crisis, and they learn their lesson. So since 2003, they've been actually preparing infrastructures, medical system, as well as human resources in healthcare system, so that they will be able to respond more properly to a similar crisis. So when COVID-19 started to break out in Wuhan and eventually reach Singapore back in January, it is something that they've been waiting for. So they've been preparing for it, and the way Singapore responded to the crisis initially at the initial stage was something that quite impressive, because of the ability of the healthcare system in containing the virus. So learning from SARS, Singapore decided to create sort of CDC of Singapore, which is called NCID, National Center for Infectious Disease, and it has magnificent facility in terms of the biosurveillance, the medical science, and as well as the human resources in tackling any crisis of virus outbreak. And NCID has been playing a central role in responding to COVID-19. They're the one who organize all of the testing, and they coordinate all the hospitals around the country to respond to the crisis. And one indications that the government has been doing a great job in responding to the crisis is the fact that none of the healthcare workers have been infected or even died due to COVID-19, and the case fatality rate has been very low as well. As you can see, as you said, 22 people died compared to 22,000 cases, confirmed cases. So that's
Yeah, that background is really important, and sounds like one where we've talked a lot in these last few weeks on in these discussions about lessons learned, which is a rhetoric that's deployed a lot, but lessons learned often don't turn into lessons implemented. And you're describing a situation after 2003. It sounds like the Singapore, the health system there, the health service really took those lessons on board. So the government
that is true. I mean,
Go ahead.
Go ahead.
So I wanted to. There was something you were talking about, though, that there was sort of a hot spot that emerged among migrant communities, and maybe people aren't as familiar with kind of the societal breakdown in Singapore. So how many people live in Singapore? How many of them are migrants? And help us understand a little bit about what it means with COVID-19 breaking out in that population.
Okay, so there are two things that I think COVID-19 is different from SARS. The first one is that this illness, this disease, have one category of asymptomatic cases, right? It's different from SARS. SARS in the spread was SARS become contagious when someone gets the virus and show some symptoms, and then they start to spread it to other people. But in COVID-19, there are cases that show no symptoms at all, and this basically ruined the biosurveillance system in Singapore, because they have to change the protocol and etc. Another factor that really changed the game here is the scale and the rate of the spread. Right, when SARS happened in Singapore, the government has the ability to contain every single case, very effectively. But with COVID-19, it spread very rapidly, and there are some cases where the government or the health authorities could not identify the source of the infection. So this is what they call the unlinked cases, right? And it is these unlinked cases that that actually caused the infection cluster among migrant workers. So and that's how it becomes sort of the different situation from SARS back in 2003. So let me just give you sort of a short descriptions of Singapore populations. In Singapore, there is a 5.7 million people living here. Citizens and permanent residents makes about 4 million, 4,330,000 people, and the rest is what they call as a non-resident, including me. I'm part of the non-resident population. But then among these non-resident populations, the big chunk is the so-called work permit holders, or basically migrant workers. So there are 700,000 migrant workers live in Singapore, working sort of a cheap labor that provide labor for constructions, manufacturing facilities, in infrastructure, technicians, and etc. And because of the cheap labor, they make a small amount of salary every month. But then the problem is that Singapore is one of the most expensive cities in the world when it comes to housing, and it is highly unlikely for this cheap labor to rent or to live in a normal housing like residents and citizens enjoy. So the solution to that is that employers provides them with dormitories where these migrant workers live in 4 to 5 stories buildings, and they have to share their room with maybe a dozen of people. So so they have to live in a room with that is used by 10 to 12 people, and and it's very packed, very cramped, and very crowded. And it is these conditions that actually become sort of the fertile ground for the COVID-19 infection to spread very rapidly, and eventually becomes sort of a national crisis, that because it contributes to the high number of confirmed cases in Singapore.
So that means the government must have intervened very quickly in terms of surveillance within those communities? I mean, still we're talking about a very low case fatality rate compared to other countries. So if these migrant laborers who are living in these very dense conditions, if there's a hotspot there, that's something that do you have a handle yet on how the government reacted to that? I mean, or has that information somehow not available? How do you become aware of it?
Okay, so I think when it comes to information, we need to, I need to show some appreciations to Singapore government, because they are quite transparent in terms of providing information of number of cases, confirmed cases, the number of testings that they do every day, the number of people that are under treatment, and etc. So there is no problem. I mean, there's no significant problem at all regarding how the government share information about the situation. And that also includes the way they responded to the dormitory crisis. And every day, Ministry of Health, holds a press conference where they explain the situations of the day, and then also give some details about the situation with migrant workers. So basically, the way they responded to the crisis with migrant workers is that they split up the workers into two big groups: those who are infected and those who are not. But then they ask them to remain in their dormitories. So basically, all dormitories are isolated. But then, of course, these workers are given paid leave, provided with food and medical assistance, and those who work in essential industries are allowed to work, but only after they go through the testing and 2 weeks of quarantine, and after the government, and then after they are make sure that they are clean, that they the government allow them to start working again. So it's interesting if you see the way health minister sort of make three categories of cases on their website. One is on a citizen and residents. Another one is migrant workers or work permit holders who live outside dormitories. So there are, migrant workers live outside dormitories. And another one is those who live in dormitories. And you see, three graphics that show, different patterns of, infection. And of course, for the past maybe, 2 months, the case numbers of the migrant workers in the dormitories has been, the highest, contributor to the total, count of Singapore. Yeah.
I want to remind people that you're listening to COVID Calls, and my guest today is Sulfikar Amir. I want to turn now, Sulfikar, I know Singapore has lots of neighbors, even though it's a city-state, and Malaysia and Indonesia, particularly. Malaysia's had, I was just looking, 114 deaths. Indonesia has had 1,278, I think, as of today. Can you speak to the case of Indonesia as best you know it? How has COVID-19 played out in that country?
Okay, Indonesia is completely the opposite to Singapore in terms of government response. Although the number may be quite comparable, but that's because the number of testing in Indonesia is very low. And there's a number, there are reasons why the number of testings have been very low. But I think what happened in Indonesia is quite similar to what happened in the US in terms of the role of the political leadership in responding to the crisis. It's from the beginning, the Indonesian government has been downplaying the crisis, and they there's some moments when the government remains denial of the existence of COVID-19 in Indonesia. So maybe I think about a month until until the government announced that there are confirmed cases in Jakarta, and since then the situation is it's getting worse and worse, especially because the reluctance of the central government in taking the necessary measures to respond to the crisis. And I guess in terms of the number of cases, it's been going up to now. And this is despite the fact that the government has implemented what they call what is it called again? The social restrictions at the large scale. Okay, it's this weird name, but there is so actually, according to the health disaster law, there are two kinds of responses that the governments can take. One is total lockdown, okay, or full regional quarantine. Another one is social restrictions on a large scale. Okay. Now, these two are basically the same. I mean, in terms of how it is implemented. The only difference is that when the government decided to take the total regional quarantine or total lockdown, the government is obliged to provide daily needs to every single citizen. Okay, and the government doesn't want to spend the money for that.
Right.
So they go to the other one, and while still providing social assistance like foods and etc., but not as much as needed. And this creates some problems in many cities because of the lack of assistance that the people, especially the low income people, receive every day. And there's been some tensions between central government and local governments. A local government here refers to the provincial and the municipal governments. So there's been some tensions. I think similar to the situation in the U.S., where you have this fragmented politics between the federal states and federal government and the state government, right? And there has been sort of a common situation in Indonesia these days, and this cause a lot of problems in terms of the effectiveness of the response to the crisis. And as you can see from data, the number of cases continue to go up, and we still don't know whether or when Indonesia will see the curve flattening, and it's quite worrying because the neighboring countries like Malaysia, Thailand, Vietnam are doing a very good job and been completed their job in flattening the curve, but Indonesia is still still dragging behind because of political as well as institutional inadequate responses to the problem.
I mean, your analogy you're drawing to the United States to me is fascinating, and one of the ways that it's very provocative, I think, is also the far-flung nature of Indonesia, the problem of governance in Indonesia, and just to bring it back to the example you were giving of SARS in 2003. I mean, you have the 2004 Indian Ocean tsunami and the incredible effect on Indonesian society of that. Were there any lessons learned from that you think have helped the Indonesian government react in this moment, or lessons there were lost somehow?
Well, there's been some cases of potential, epidemic in the past, including, of course, SARS, MERS, and avian flu, right? And during SARS, Indonesia was quite safe. Only 3 or 4 people were infected. And that's probably due to the fact that the virus, cannot live in a tropical, climate, right? And during the MERS, situations, Indonesia also responded quite, well, and also avian, flu. So there is an infrastructure there in terms of hospital capacity, medical doctors, and etc. And I think if we look back, 5 or 10 years ago, Indonesia did quite well in terms of responding to potential outbreak. But then in this COVID-19 pandemic, it seems that the government is not using the resources enough to create some kind of massive ability, both from the government side and from the community side, in responding to the crisis, in withstanding to the virus outbreak. And well, Indonesia learned the lesson from tsunami in 2004 and also from other outbreaks. But then, institutionally speaking, there's no one single agency responsible for handling the crisis. I mean, at the moment, the only agency that has sort of closest authority in handling outbreak is the National Disaster Mitigation Agency. So it's sort of a FEMA of Indonesia. But the problem is that this agency does not have enough capacity and expertise in handling this kind of situation, and it has been I think it's struggling not only because of the lack of expertise, but also because of the lack of authority given by the central government. So there's been some bureaucratic politics that place this agency to play its role more properly, and especially because of the tensions between ministries which tend to undermine the severity of the crisis, and those who think that Indonesia should do more in terms of keeping people from going to work, going to school, and etc. And so the interest between the economic, the tension between the economic interests and the concerns of public health has been sort of I would say dividing issues that eventually cause the government to be even more inaptitude to respond to, or to make good policy and effective action.
Yeah, I see this comparison now that you've made to the United States is even more clear to me. I want to remind people also, I'm speaking with Sulfikar Amir on COVIDCalls, and I want to encourage you, if you want to get a question in, this is a good time to do it. Use YouTube live chat or put it up on Twitter. So Sulfikar, I was remembering, well, these days, remembering being anywhere outside of my house is quite something. I was remembering being with you at MIT a few years ago when there was a screening of your documentary Healing Fukushima, and I believe your collaborator Shilin Lo was also there at that, and Mike Fisher was there giving commentary, and I was reading back through Mike Fisher's commentary on that, and I just wanted to first just pause with that and remember that time with you, because it was really great, and really encouraging people to watch the film, but I wanted the thing I've been dying to ask you about is that, so in making that film, I mean, you travel to Fukushima and you interview doctors who had made the decision to stay in Fukushima Prefecture despite the unknowns of radiation. And one of the things that's been really challenging with the COVID-19 pandemic is seeing it, because it's a disaster that occurs behind closed doors. It occurs in emergency departments. Even, I read the obituary to everyone today, that this story of families saying goodbye to their families at the hospital, basically. It's the last time they can see them. And I think you've grappled with that already as an artist. I mean, I think this is part of what Healing Fukushima is about, is capturing risk that can't be seen and the psychological impacts of that. I just have been wanting to know what's on your mind as a filmmaker right now, thinking about COVID-19, how you would picture it. Maybe it's too early to give you this. I don't know if you're thinking of making a film. I hope you are, but what's on your mind about seeing this disaster?
Well, one thing that we can distinguish, Fukushima disaster and this COVID-19 pandemic is that when the nuclear disasters hit, Japan was alone. Okay? So the Japanese society was alone. They're the one who experienced the disaster. So we don't really see, what really happened in Japan. Only in the aftermath that we have a sense that, okay, this is the experience, the traumatic experience that the Japanese, especially people in Fukushima, had to go through in order to survive the radiation, hazard. And now back to COVID-19 pandemic, I feel like we are now in that situation, but this time Japan is not alone. Everyone is having it. Right, but also different in terms of the time, frame, because we're dealing with a much longer, crisis compared to, the nuclear disaster. Well, of course, the radiation hazard in Fukushima is still happening actually up to now, although maybe the scale and the magnitude of it has been much, lessened and reduced with decontamination measures undertaken by the governments and the local government in Fukushima. But then the COVID-19 pandemic is something that will continue to escalate, and we don't know when it's going to end. Of course, everyone hopes that the vaccines will be, developed, so as soon as possible, so that we can, start to enjoy a normal life. But then this is a moment where I see that Healing Fukushima is, highly relevant, because the anxiety, the fear, as well as the uncertainty, is very much the same, right? The way we interact with other people, the way we are losing our trust to the ability of institutions in providing protection, to the people. And in terms of the uncertainty of the crisis, because of course every day you will see new publications written by medical doctors and etc. about COVID-19. So we get an explosion of knowledge about COVID-19, but then this a large amount of knowledge does not guarantee that we have really a real understanding about about the crisis, about the virus, about how we what we need to do to cope with it, and not to mention the aftermath of this, because I don't know, maybe it's too soon to talk about what we will feel when the whole pandemic is over. But then I think the aftermath will last long as well because of the impact. It's so much deep and so much painful for many people that it's going to be something that that changes our history as humankind, as a modern society, and this is something that will will deserve sort of new reflections both by humanities and social scientists in understanding what really happened with our society.
When you did the interviews for the film Healing Fukushima and you talked to doctors there, what did they say when you asked them the question, why stay amidst the danger, the uncertainty? What kind of answers did they give? Because I think if we're looking for solidarity and hope right now, that's one of the places I look for it.
Yeah. I think the strongest motivations that I sense from their commitment to stay is that they are medical doctors, so it comes from their a field of expertise that somehow oblige them to stay in order to survive, not only for themselves but also for the community. So there's a strong bond between their expertise as well as the commitment to to provide protection to the people. So it's something that we Lynn and I we co-author a paper based on our interview, and we call this a sort of, I forgot the term, serviceable expertise, something like that, which is very much inspired by Sheila Jasanoff. So if you can read the article and appreciate your comments on it. But basically, we see that this commitment and motivation to stay and become and provide medical service to the people is due to the nature of their expertise that is institutionalized in the hospital, in the medical, in the care facility, as well as the interactions between the doctors and the community.
Some of those very doctors are probably providing COVID-19 support.
Oh yeah, definitely. Yes, yeah.
So this will be something that you'll be following up on, I'm sure, in your own research.
Already have some ideas.
You already have some ideas, and I'm sure you do. Well, I think that's a really fascinating set of observations to think with, sort of in closing out, that it was this expertise and this commitment that comes through the practice of being a medical doctor. And that transcends many other kinds of boundaries. This pandemic has been carved up as a national thing, or maybe in the United States now, unfortunately, it's a Democratic thing or it's a Republican thing. But I've been looking for places also where there's resilience and where there's reservoirs of capacity and hope. And it's absolutely in the kind of things you've been talking about. So I know we're up on time here. I just wanted to give you the last word. How has this changed your own research?
Well, for the past 2-3 months, I've been doing some small projects to help governments in Indonesia in dealing with the crisis. So we created this small lab called Social Resilience Lab in an NTU, where me and my students developed some models and simulation, as well as providing some sort of guidance for disaster policy, disaster response policy for governments in Indonesia. So I've been involved with a number of groups, civil society groups in Indonesia that collects data from from the community. So it's a sort of a crowdsourced, data collection system as a sort of alternative source of information in addition to what the government, what official information is provided by the government. And we've been helping, local governments in identifying the problems in calculating the infection rate, as well as providing some guidance on how to mitigate the crisis. So it changed quickly what I've been doing basically. So yeah, and I'm quite fascinated by what I've been doing now.
Yeah. Well, I want to remind people you've been listening to COVID Calls, and we are on Monday through Friday at 5 p.m. Eastern Time. Tomorrow, we're going to talk about lungs, breathing, and the pandemic with James Dodd and Javi Carroll of the University of Bristol and Sarah Malov from the University of Virginia. And today, I've been talking with Sulfikar Amir. Sulfikar, thank you so much for making time very early in the morning there to fill us in on what's going on in Singapore and Indonesia and to talk about films and this interesting work you're doing. I think we're going to have you back in the summer to continue the conversation.
It's my pleasure, Scott. Thank you so much for inviting me.
Stay healthy. We'll see you all tomorrow, 5 o'clock.
Goodbye.